Hello everyone, this is Dr. Madhusudan Rao and the program I teach medical students. Topic of today's lesson is on Bell's palsy. Bell's palsy is the episodic acute onset of the paralysis of the facial muscles due to the injury to the facial nerve. It is idiopathic of, of sudden onset and most of the patients, they recover completely even without the treatment. The cause is not known well. Before we proceed with the real topic, let us know a few points related to the facial nerve. Facial nerve is the motor, secretory, and sensory fibers. Its motor part innervates the muscles of facial expression. Besides, the stapedius muscle during its course to the petrous part of the temporal bone. It also carries the parasympathetic fibers to innervate the salivary glands and the lacrimal glands. Its lingual branch contains the corda-tympanic branch, which carries the taste fibers from the anterior two-thirds of the tongue. Well, facial nerve nucleus is located in the upper part of the pons, inferior lateral to the abscess nerve nucleus. It courses in the pons along with the closer to the abscess nerve fibers and exit at the pontomedullary junction. It enters into the internal acoustic meatus and finally exit into the tympanic segment of the facial canal through the internal acoustic meatus. During its course, it gives away a branch to the stapedius muscle. After exiting from the stylomastoid foramen, well, it gives away the branches to innervate the muscles of facial expression and parasympathetic branches as a secretory motor branches of the parasympathetic to the salivary as well as the lacrimal glands. And its injury occurs either in the upper motor neurons or in the lower motor neuron. Upper motor neuron injury results in the involvement of the lower face only, because upper face is bilaterally innervated. So the lesions in the upper motor neuron results in the weakness of the lower part of the face on the contralateral side. Whereas lower motor neuron lesion of the facial nerve, which could be at any level from the site of the nucleus in the pons down to its exit. Well, lower motor neuron lesion is characterized by the paralysis of the total face, upper as well as the lower face on its side of the lesion. Okay. Well, with this brief discussion related to its anatomy, let us proceed with the Bell's palsy. We are going to touch this topic in terms of its etiology, pathophysiology, clinical presentation, and management. Well, Bell's palsy is an idiopathic, acute episode of facial weakness, secondary to the injury to the facial nerve. Recovery is complete in most of the patients. Okay, as the etiology is unknown, certain risk factors have been described for the cause of Bell's palsy. What is this risk factors? Well, diabetes, pregnancy, viral infections, trauma, neoplasms, okay, are associated with the patients presenting with facial palsy. Facial palsy is also described with in other syndromes like stroke and intracranial tumors and Ramsay-Hunt syndrome. That is the zoster infection involving the geniculate ganglion of the facial nerve. And is also incriminated with the Lyme's disease. Okay. Well, other infections of the brain like meningitis, etc. Well, isolated Bell's palsy is idiopathic and simple. If it is associated with the other features like hemiparesis, hemianesthesia, vertigo, loss of balance, one should think about a complicated facial nerve palsy due to the lesions in the brain, like stroke or tumors. Let us go in brief. Bell's palsy is the most common lower motor neuron type of facial palsy. Okay, associated with the weakness of sudden onset. Well, age of incident occurrence of this Bell's palsy is most common between 15 to 60 years of age. The average age of occurrence is around 40 years. Okay. As I told you, by definition, Bell's palsy is idiopathic. That is the reason why the treatment is controversial in these patients with Bell's palsy. The viral infections, trauma, and neoplasms are other risk factors that have been incriminated. Well, in most of the patients, recovery begins around 2 weeks to 6 months after the onset of paralysis. They recover normal strength. Well, the most common site of occurrence of the injury to the facial nerve is in the facial canal, that is the labyrinthine segment of the facial nerve, which is the narrowest part of the facial canal. It is associated with inflammation and the compression effect of the nerve, resulting in the ischemic injury. Okay, but it is of all temporary phenomena. The recovery is complete in most of the cases, even without treatment. Besides the involvement of the muscles of facial expression, it also be associated with dysfunction of the salivation, okay, dysfunction of the tears production, that is due to the involvement of the lacrimal glands, and associated with the disturbance of taste in the anterior two-thirds of the tongue. Well, these findings are secondary to the involvement of parasympathetic fibers and the taste fibers that are carried in the lingual nerve through its cardiac branch. Okay, so what are the few aspects of epidemiology? As I told you, the common age of occurrence is between 15 to 60 years of age. Around 40 years of age, most of the patients are observed. Male and females are equally affected. There is an incidence of 15 to 20 per 1 lakh population. The recurrence is observed in 15 to 20% of the patients, and around 70% of the patients recover completely with or without treatment. Well, diabetes and hypertension are observed as the risk factors. Besides, obesity, pregnancy, viral infections like herpes simplex, varicella zoster, Epstein-Barr virus, adenoviruses, cytomegalovirus. It is also observed in the patients with mumps, rubella, Coxsackie viral infections. There are congenital factors associated with the facial nerve palsy, okay, involving the developmental anomaly of the facial nerve nucleus. Well, trauma, neoplasms, and autoimmune phenomena are also described in the facial nerve injuries. Well, other etiological factors that have been described are stress, exposure to cold, immunocompromised states like HIV, and previous episode of Bell's palsy. The nerve shows degree of inflammation and swelling, and it is subjected to compression injury in the narrowest part of the facial canal. Well, patients may ask you, is it a serious condition? The Bell's palsy as such is not serious. Most of the patients recover completely, as I told you. But in certain cases, it could be the part of the serious condition like stroke. In such occasions, the patients may present with contralateral hemiparesis, contralateral hemianesthesia. Sometimes there could be impairment of visual and auditory functions, loss of balance, aphasia, headache, etc. In these situations, it is a complicated case of facial nerve palsy. One should think about the lesion in the higher centers. So, in these situations, one needs to have a neurological consultation. Coming to the clinical presentation, weakness occurs all of a sudden. The patient may say that, "Hi, doctor, I've been very well. I was normal when I went to the sleep. When I got up in the morning, I look, my face is twisted, and it has happened suddenly." Then that is the history that brought out by the patient. Well, when you examine the patient, there is a loss of frontal creases, there is a drooping of the eyebrows, widening of the palpebral pressure, and there is a difficulty in closure of the eyes, and there is a loss of or flattening of the nasolabial fold, drooping of the angle of the mouth, and the smile is asymmetrical. And the angle of the mouth and the side of the lesion, it cannot move as much as the normal side. And there is a drooling of the saliva on the side of the paralysis. When you examine for the taste, impairment of the taste on the anterior 2/3 of the tongue. Well, there could be hypersensitivity to sound, and there could be ringing sensation in the affected side. Well, the patient may also say that he feels heaviness on the side of the paralysis. Well, these are the clinical features one can easily diagnose a case of Bell's palsy. By looking at the patient and asking to smile, there is deviation of the angle of the mouth to the normal side. And when you are asked to close the eyes, he cannot close the eye on the side of the lesion. Absence of creases, frontal creases on the side of the lesion due to the weakness of the frontal belly of the occiput of frontalis. Inability to close the eyes is due to the weakness of the orbicularis oculi. And asymmetric smile is due to the weakness of the orbicularis oris. So, well, when the patient is asked to, the muscles of facial expression of voluntary action are affected, but the emotional expression is spared in these patients with facial palsy. Well, look at this patient with Bell's palsy on the right side. So there is absence of frontal creases and drooping of the eyebrow, okay, widening of the palpebral blood pressure. Patient is unable to close the eye on the affected side. There is a symmetric smile and drooping of the corner of the mouth. This is the pathway of the patient now. You have got the nucleus of the patient now at the upper pons and motor nucleus that innervate the upper face receives the supranuclear fibers from both the hemispheres. Okay. Whereas that nucleus that innervates the lower face receives its fibers from the contralateral side of the hemisphere. Okay. So the involvement of the supranuclear fibers results in the paralysis of the lower face, sparing the upper face. Whereas the lower motor neuron lesion results in the paralysis of muscles of the upper face as well as the lower face. This slide shows the patient is taking the treatment. We are providing the eye care, prescribing the eye shield to protect the eye from injury. Well, once the patient has come with the clinical features characteristic of Bell's palsy, typical Bell's palsy. That means typical Bell's palsy is that one. There is paralysis of the upper as well as the lower face without other findings related to the higher centers like seizures, like hemianesthesia, like hemiparesis. It is simple Bell's palsy, which can be clinically diagnosed with history and the detailed clinical examination. No laboratory workup is required. But in the event when you suspect, okay, there could be other features and the lesion could be in the higher centers, then the diagnostic workup should be done in detail. But by and large, if the patient is suffering from Bell's palsy, you can go for a MRI, wherein you can identify the edema of the facial nerve associated with inflammation. And you can exclude other tumors like schwannoma, like hemangioma, etc. Well, CSF analysis should be done in atypical cases of Bell's palsy to exclude infection like meningitis. In the same way, MRI can be a preferred imaging, that is imaging test that is advised in order to identify the facial and inflammation and other tumors, as I told you, schwannoma and hemangioma and other space-occupying lesions. Well, electromyogram and nerve conduction studies should be done in order to identify the severity of the patient now that is affected. It will help assist in the grading of the Bell's palsy, depending upon the, percentage of electrical potentials. And electromyogram can also be used as a follow-up test to assess the degree of recovery from Bell's palsy. Well, looking for the Lyme's disease, testing for the Lyme disease in terms of imaging is not regularly required, but you can work out for the Lyme's disease with the history of tick bite, presence of rash, and clinical signs of arthritis. In the event the patient does not recover beyond 2 weeks and paralysis persists beyond 6 months, then you can work out for the Lyme's disease. Well, in the same lines, auditory evoked potentials and audiometry can be done in patients with auditory dysfunction. Then coming to the treatment, and there is no clear-cut guidelines with regard to the treatment of Bell's palsy because it is idiopathic. But steps of management include 1. Eye care, steroids, antiviral drugs, and rehabilitation, and plastic surgery. Eye care is mandatory in all the patients in order to avoid the visual loss because exposure keratitis due to dryness, it may involve the damage to the vision in course of time if neglected. So we advise eye shield and lubricant drops, the tear drops, to have the adequate protection. Steroids are regularly administered, and patients given the combination of steroids and antiviral drugs in severe form of Bell's palsy, there is definitely improvement with regard to recovery. Rehabilitation is mandatory even in the early stages. You can institute massage and electrical stimulation, passive exercises, not active exercises in the initial stages. Once the patient shows some degree of recovery, you can go with the continue massage therapy and proceed with the active strengthening exercises. If in certain cases when there is no adequate response, plastic surgery is indicated. Well, these are certain other slides wherein shows the Bell's palsy and exercises. Then coming to the prognosis. As I told you earlier, Bell's palsy patients, they recover completely to the extent of 80%. The relapse could occur in 15 to 20%. And chronicity when in old patients more than 60 years, when there is a total facial no palsy, and when the patient presents with the loss of taste and salivation, these are the patients they suffer with chronic paralysis, weakness of the muscles. Complications includes loss of vision, complete facial paralysis, and abnormal growth of the facial nerve fibers. Well, thank you very much, my dear students, for patient listening. Well, this is the common facial nerve paralysis involving its lower motor neurons. That is the peripheral branches of the facial nerve. As I told you, it is of idiopathic, recover completely even without treatment, and follow-up is required to monitor the extent of recovery. The monitoring is basically by the electromyogram. When there is a baseline electromyogram shows only 25% or less than 20%, 25% of the loss of electrical potentials, the patient can be put on the conservative treatment. The counseling is important in order to provide the follow-up, physical therapy, okay, to get the early recovery. That's right. Well, This is all in brief about the Bell's palsy. Thank you once again for patient listening. We'll meet again in the next class. Until that time, bye-bye.